Okay, great. I think we're live now. Thank you all for being here. Welcome to the October EP&R Lunch and Learn, covering biological diseases, or as Donald Moore put it, the diseases du jour. So I'm going to talk a little bit about high priority communicable diseases right now. I mentioned I'm Dawn Sadie. I'm an EPI Program Manager in the Division of Surveillance and Investigation and the Office of EPI here at VDH, and I'm happy to get to spend a little bit of time with you this morning to talk through some of these diseases. Okay, so on the agenda this morning, we're going to first take a quick tour through some respiratory diseases, and I'll talk about influenza, respiratory syncytial virus, and just a little bit about COVID-19. Then I'm going to transition to talking about the monkeypox outbreak that is ongoing, and touch on Ebola virus disease a little bit, and then hopefully have a few moments for some questions and discussions if there's anything that you all want to bring up related to these diseases. Okay, so first, just to touch on influenza. In public health, the flu has always been a disease that's been high on our priority list. It affects between 3 and 11% of the US population every year. That's a huge number of people, between 9 million and 41 billion illnesses annually here. As well, flu can cause hospitalizations, especially in those with underlying conditions, and it also can cause deaths. Most importantly, it is a vaccine preventable disease, and even when the vaccine is not a perfect match, it does reduce illness duration and severity. So here at VDH, we do track a lot of data related to flu every year to understand trends, to see what viruses are circulating, to see what populations are most heavily affected by disease spread. Just taking a look at where we are now with influenza. While the COVID-19 was in the pandemic phase, we had some milder flu years. That could have been due to changed behaviors of individuals, reduced congregating, mask use. But if we look at what happened in the Southern Hemisphere, which at least for Australia was a fairly severe influenza season that they've been characterizing as the worst flu season in 5 years, it could be that this year in the United States that we're in for a more severe flu season. Looking at where we are now for the last reporting week, that was September 25th through October 1st, we did report widespread flu activity. We expect flu season to be sometime between October and May every year in the United States, but October is a little early for us to be already reporting widespread flu activity. The flu activity levels in Virginia are a measure of the geographic spread of disease, and so to be at widespread, we would need at least 3 of the 5 health planning regions reporting increased ILI activity, and for this reporting week, 4 regions were above baseline ILI, and that is what led us to the widespread flu activity level. If we look at influenza-like illness, or ILI, from our syndromic surveillance data, so visits to hospital emergency departments or urgent care centers, we did see an increase in 10%, an increase of 10% in ILI from last week to this week. 3% of those emergency department and urgent care center visits were for ILI, and I wanted to tease out that those in the 0 to 4-year-old age group had the highest percentage of visits due to ILI, and that was at 12.3% of the total visits. So flu conditions that are diagnosed by what we call confirmatory methods, so that's a PCR test or DFA or a culture, are reportable in Virginia. And we did see 85 confirmatory flu labs received for that reporting week, which was a 60% increase over the reportable disease labs from the previous week. And then I want to mention that while it's early to predict what will be the predominantly circulating strain, we have seen influenza A H3 as a predominant strain circulating in Virginia this season, and that is also the strain So the top graph on this slide shows the influenza activity levels at that highest level being widespread. So you can see where we are this year with the yellowish orange line being at the highest point, reflecting the widespread flu activity. And then that bottom graph shows the influenza-like illness visits broken out by region. So the different colors on the graph are the different regions, and the highest right now is the green. You can see that's being reported from the northern region of the state, and you can see the upward trend in ILI moving across the graph towards the right. Okay, so that's influenza. I do want to just shift for a second now and mention another common respiratory pathogen, and that is respiratory syncytial virus, or also RSV. RSV is not a reportable disease in Virginia, but we do have some data available on the condition through our syndromic data surveillance, and as well through a national reporting system called the National Respiratory and Enteric Disease, National Respiratory and Enteric Virus Surveillance System. That's also called NERVS. RSV can be a milder illness causing symptoms similar to common cold, so sort of upper respiratory conditions. But for individuals like very young infants, especially premature infants or those with underlying lung issues, it can be quite a severe disease and lead that infant to spend some time in the neonatal intensive care unit. So there's a monoclonal antibody that can be given to premature infants to try and prevent that severe disease. And the availability of that sort of preventive treatment is one of the reasons that there is a national surveillance system set up for RSV. So clinicians look at trends in RSV detection and make decisions and offer that monoclonal antibody to preemie infants essentially during the RSV season. But what's interesting about RSV is we're seeing an uptick earlier than usual. That top graph is data from our Essence system, and you can see the sharp increase in recent weeks. Compared to the prior reporting week, the ED and urgent care visits due to RSV increased 11%. We also did have an outbreak of RSV reported from the northern region in daycare. And then if you look at the RSV trends reported through that national surveillance system, this is NERVS data specifically for Virginia. And labs that participate in NERVS in Virginia send their weekly data to CDC, and this is showing they report to them the number of tests that were administered for RSV and the number that were positive. So the purplish top line is the number of PCR detection tests that were positive, and the bottom are the antigen tests. The percent positivity for the last reporting week was increased from the prior week, and the percent positivity of the test was 11.9% for RSV. So it's definitely something to keep on the radar as it affects, I mentioned, premature infants and very young individuals. Okay, couldn't get by without talking about COVID-19 just a little bit, since we've been in the midst of this pandemic and responding for the last 2.5 years. It was important to make a note of it. Of course, we are tracking a lot of data relative to COVID-19 here at PDH, and this graph on the top is showing reports from our Essence surveillance system, so ED and urgent care center visits due to COVID-like illness. So they look at chief complaint, anything that's symptoms of fever, respiratory illness, loss of taste and smell, or visits that mention COVID-19 as a reason for visit. And we're in a good spot right now. Finally, time is across the bottom, so we are all the way towards the right end of the graph, and you can see a slight downward turn in those visits The visits did decrease 7% for the current reporting week compared to last week. We are still seeing quite a bit of outbreaks due to COVID-19. For the reporting week, 32 of 33, or 97%, were due to COVID, but that is actually a decrease in the number of respiratory outbreaks reported. So the trend is in a good direction. The bottom chart shows the COVID-19 numbers by region, and all regions are showing a decrease in the number of new COVID-19 cases per 100,000 population. So that's definitely trending in the direction that we want it to go. And 4 of 6 regions are under the 15 CLI ED visits per 100,000 population, which again is a positive trend. So while it has been a long pandemic for all of us, we've had over 2 million cases of COVID diagnosed in Virginia and 96 million cases diagnosed in the United States. We're in a good place with the trends, with access to vaccine, with availability of therapeutics. So we are hopeful that COVID-19 will settle into possibly a seasonal trend moving forward. Okay, leaving our respiratory diseases and just turning for a moment to talk a little bit about monkeypox. Monkeypox, the first ever case of monkeypox was reported in Virginia in May of this year. But prior to that case, we did support the 2003 outbreak in the United States that was linked to imported animals, specifically prairie dogs. But that outbreak, there were 47 US cases. Most of those cases resulted from just direct exposure to infected animals, and there was very little person-to-person transmission. And the nature of this, the current monkeypox outbreak, is very different than that one. I mentioned that we had our first case back in May. That case was interesting in that it is not associated. The strain that was identified in that early May case was linked to travel to an endemic country and was genetically distinct from the current monkeypox outbreak. Subsequent to that first travel-associated case, we have seen increase in the number of cases reported in Virginia. Now we're reporting 510, and those cases have been linked to the strain of monkeypox that started in Europe and spread subsequent after that. So monkeypox as a disease, you all probably are familiar with, causes fever, chills, regional lymph node swelling, and then that characteristic rash that starts on the body a lot of times at the site of the initial exposure and can spread. And then the lesions may start out as macules or small pink dots, and then they progress through a series where they may fill with fluid, and they get very firm and deep-seated and pustular, and then eventually they scab over and fall off. Some individuals, it may take up to 2 weeks or even longer, a month, to go through the process of new lesions popping up across the body and then progressing to that stage where they scab over and fall off. So it can be quite a lengthy illness for some individuals. However, the good thing is that it does not often result in a severe illness. So we've only in Virginia seen about 22 hospitalizations due to monkeypox. That's about a 4% rate, which is similar to the rate that's being seen in the United States. And we have not reported any deaths due to monkeypox, which is good. There have recently been reported 2 deaths in the United States due to monkeypox. And a positive note is that the number of new cases reported by week has been trending downward in Virginia and in the United States since late August. So that's good news for us in terms of where this outbreak may be headed. Just taking a closer look at some of the data on our cases of monkeypox in Virginia. The majority of cases, so 95% of the cases, are male. Early in this outbreak, all of the cases were in the northern part of the state. As time has progressed, those cases have become distributed across the state as more cases have popped up in different regions. So now we're seeing about 50% of the cases for the northern region, a little more than a quarter in the eastern region, and then the remaining 24% or so spread across the central, northwest, and southwest parts of the state. The majority of cases when looking at different age groups are in those 20 to 59 years of age. And then looking at self-reported race and ethnicity of concern, almost 42% of cases report their race as Black and a little over 16% as Latino. So ensuring equity and approaches to monkeypox testing and treatment and prevention is essential, reducing stigma associated with seeking care, and ensuring equitable access to vaccine are areas that VDH is focusing on as priorities in responding to this outbreak. I mentioned some of the trends in monkeypox in Virginia as compared to cases across the US, and you can see that reflected here in the slides. The top bar shows the epi curve essentially for the United States for monkeypox for this outbreak, and you do see a downward trend in cases reporting starting mid to later in August. The bottom left chart is monkeypox cases by age and gender, and the dark blue are males. And so you can see that males are making up the majority of national cases, and as well concentration is in those middle age groups, so the 20 to 60 age group. And then on the right, you see the case counts for each state. And Virginia did cross the threshold into over 500 cases. So our case counts are up there, but not nearly to the level that the top reporting states are. So California has over 5,000 cases. New York has over 4,000 cases, and Florida, Texas, and Georgia are reporting around 2,000 cases each. So everyone is sort of asking the questions about, what's going to happen with this monkeypox outbreak. This is sort of a newer disease for us to see in the United States, and certainly in Virginia, only since over the last few months have we seen cases. And so it's normal to sort of question, well, where is this outbreak going to go? What's going to happen? It is apparent that the growth rate of the outbreak in the United States is slowing. And CDC wrote a very interesting technical report. I've included the link to it here, which you guys can follow up and read on it. They're attributing the decrease likely to a combination of factors. Vaccination is a very important one. The Jynneos vaccine, the 2-dose series, is likely contributing to that downturn. However, CDC did do a study, a survey of individuals in the gay, bisexual, and MSM community. In that survey, they indicated that they were changing their behavior due to this monkeypox outbreak. So that could be contributing to the downward trend in cases. And another thought is that increases in immunity due to natural infection may be contributing to decreased transmission in populations that have high-risk behaviors and may have been spreading the disease to a large number of other individuals. So those are the conjectured reasons for the downturn in cases. In EPI, we like to think about the reproduction number, or the R naught, and that's sort of the bottom graph, what the bottom graph is showing. So since late August, the R naught, or the reproductive number, has been under 1. That means that, for every case, they are spreading the disease to less than one other person. So on average, less than one other person. And when it's less than 1, the hope is that the numbers are decreasing and that trajectory of the outbreak is waning. So in the future, it's like, where are we going? What's going to happen with this outbreak? CDC is saying that the most likely short-term scenario is that daily cases will continue to decline or plateau. However, there is some uncertainty over the longer-term trajectory. So what's going to happen months from now? And they're saying, well, that will depend on the uptake of the vaccine, how interested people are in continuing to get monkeypox vaccine in the future. It'll depend on the effectiveness of post-exposure prophylaxis. So how effective, studies will tell how effective JYNNEOS is at decreasing disease once someone has been exposed. The role of asymptomatic spread, so whether, and those studies are ongoing with CDC right now, and then, of course, whether or not there's any mutation in the virus to make it more transmissible in the future. So those remain unknown, but at least for right now, we're hopeful about where the numbers are going. Just for a quick moment here, I wanted to mention Ebola virus disease, because this has certainly been a topic of discussion at BBH and in the news media lately. There is an outbreak of Ebola virus disease occurring right now in Uganda, in Africa. It was announced on September 20th, and the numbers that CDC is reporting in terms of cases are shown on the screen here. The numbers that are being reported in the media are actually much higher than that, which is concerning. The outbreak in Uganda right now is caused by the Sudan strain of the Ebola virus. That is of note because that strain of Ebola virus, there is no effective vaccine for that strain or therapeutics. And to detect that strain of Ebola virus requires a special test that actually our state public health laboratory, DCLS, was just validated for. So we're very lucky in Virginia that DCLS is one of the labs that can detect this strain of Ebola virus. I do want to note that while this is definitely a disease that is of concern and on our radar and important, we're doing a lot of preparations for it right now. It has not spread out of Uganda, and there are no reported cases in the United States or in Virginia right now. We are, however, working on standing up our monitoring of individuals who have left Uganda within the past 21 days and are entering the United States. Just for you all's note, there is a level 2 alert for Uganda, which means that individuals should avoid non-essential travel to that area, to the outbreak areas, and practice enhanced precautions. So our U.S. government decided that this outbreak was of concern enough in Uganda so that anyone leaving Uganda within the past 21 days will be routed to one of 5 U.S. airports for screening. And one of those airports is Dulles International Airport, which is located in Loudoun County, Virginia. So individuals leaving Uganda may travel to Europe, but when they enter the U.S., will have to go through one of these airports. They'll do a screening of the individuals, and if they have any symptoms, they will be evaluated and may be sent to a Virginia hospital for assessment. If they're not a high-risk individual, they will be allowed to continue their travel to their final destination. So anyone who is entering the country that goes through either Dulles or any of the other 5 airports that has a final destination as Virginia will receive information about those travelers and will enroll them in our traveler monitoring program. When we receive notification of the travelers, what BDH does is to reach out to them to conduct an initial risk assessment. And so we ask them where they went in Uganda, if they were in an outbreak area, and any potential high-risk activities or exposures while they were there. Those questions sort of lead to a risk level that's assigned to the individual, and so they've become either high, some, or a low risk individual. High risk individuals have had some exposure of concern. Perhaps they were a U.S. citizen who was a healthcare worker who was helping out in response efforts, and they had an exposure to a known case, and they possibly had a breach in PPE or some other percutaneous exposure that makes them high risk. High-risk individuals have to quarantine at home for 21 days. They're not allowed to travel, and they receive outreach from public health staff every day for that 21-day period. Some risk individuals would have traveled to an outbreak area, so one of the 5 districts in Uganda experiencing Ebola virus disease right now. And they are not restricted in their movement. They can go about their normal day-to-day activities as long as they remain well. But they do have to check in with public health if they're traveling more than 50 miles outside of their home base, and they'll receive a touch point from public health every 3rd day. Low-risk individuals would have traveled to Uganda, but not to the specific outbreak areas. And again, they don't have movement restrictions. They are asked to notify us in advance of travel and have that approved through public health. And then we'll receive monitoring once a week. I'm sorry, there's a typo on this slide. That should say for low-risk monitoring every 7th day. As part of this process, if any of these individuals develop symptoms of disease, public health assists in the evaluation in coordination with hospitals to conduct testing as needed, and that will involve coordination with our state public health lab for testing. DCLS has a testing workflow, which I've placed on the left side of this slide just for your reference, but they are testing for this strain of Ebola virus, and we'll have results available for us very quickly. So it's natural to think what's going to be the trajectory of this outbreak. The World Health Organization has expressed concern for Uganda because of the way this outbreak emerged. It likely was simmering for several weeks before it came to the attention of the public health officials there, and that sick individuals went to multiple facilities where infection control practices were not implemented. So spread to healthcare workers as a reality, and spread to large numbers of individuals who participated in traditional funeral rites. So their local resources in Uganda may become quite overwhelmed, and there's concern for that. However, the spread outside of Uganda to other countries, the World Health Organization has assessed the risk of that as low. So it remains to be seen. We do have experience in traveler monitoring and responding to other outbreaks of Ebola virus disease. There was one in DRC last year, and I pasted some of the travel monitoring data there on the left side of the page. That outbreak was declared over, so that is definitely a success story. It's hard to say if this outbreak in Uganda will follow a similar pattern. It is a different strain. There is no vaccine available, so there is concern that it may not be the success story that the outbreak in DRC and Guinea was last year, but I think we can be hopeful that response efforts are now engaged, and in countries outside of Uganda, that this monitoring of travelers will lead to the early identification of cases and hopefully reduce spread to others. So that's all I had to say about Ebola. I did want to close with a note. We talked a lot about diseases that have become pandemics and some that may have the potential to become a pandemic, and it's hard to predict what's going to happen with diseases. It does seem like the amount of time between these big public health responses is decreasing, and that's definitely a concern. I was kind of impacted by this quote from the CDC Global Health that says the disease threat anywhere is a disease threat everywhere. So while Uganda and Ebola virus disease may seem far away. It's really not that far away, and responding to the disease and supporting efforts there and supporting traveler monitoring here and being on top of that is important for all of us because the world is becoming smaller and smaller every day. And our next public health thing could be one of the diseases on this list, on this world map, or it could be, disease X that's yet to be identified. So that is all I have to say. I guess it looks like I'm right at about time. So I'm not sure what time we have for questions, but
about 10 minutes.
A few minutes we do. Okay, so Donald saying we may have a few minutes for questions or comments if anyone wants to type that into the chat. So,
or unmute themselves.
Or unmute themselves as well. So welcome you guys to do that now if you would like to do so. Quiet on all fronts.
Yeah.
All right. Well, thank you guys for being here today. We'll hang out for a couple minutes and monitor the chat if anyone has any thoughts to share, or comments or questions. Thank you so much.